So thank you everybody for joining us tonight. I was explaining to Val and Carl before we started that my outfit choice is a little bit uh, inspired by both the presentation tonight and my work today. I had a maid provision this afternoon, and I always like to wear flowers whenever I provide, so something with floral on it, so hence my flowered sweater. But I put my ghost earrings on in honor of the fact that tomorrow is Halloween, and you will see through the presentation that I've weaved that through. So tonight we're going to talk about waivers of final consent and advance requests. Are they tricks or are they treats? So here are the disclosures for the Scientific Planning Committee as listed. And these are my disclosures. So I'm a member of a number of organizations, both in relation to palliative care and to medical assistance in dying across the country. As Carl mentioned, I'm an employee of Ontario Health at Home. I also teach at a number of post-secondary institutions and have helped to develop and review the Canadian MAID curriculum through the Canadian Association of MAID Assessors and Providers. I do not have any potential conflicts of interest, though the scientific committee has reviewed my slides, and I was aware of the things I needed to include or exclude in regards to mitigating potential bias. So by the end of our time tonight, I'm hoping to achieve these 4 objectives. So initially, I'm going to review the history of MAID and the legislation that we're working under currently and how advanced consent became legal in relation to MAID. I will then identify when the use of a waiver of final consent might be appropriate. And then distinguish between what a waiver of final consent is and an advanced request. And then lastly, we'll look at some of the practice concerns that arise when there's a loss of capacity and perhaps some things that people haven't thought about in the past. So we have lots of polls tonight, so lots of interaction. First one, I'd like to know how you are involved with MAID. So the options are as a MAID provider, an assessor only, a MAID coordinator, an IV or support nurse, or other, or I'm not involved in MAID. So we'll give you a number of seconds to complete that poll. It just gives me a sense of who I'm talking to, so I appreciate that. Awesome. Okay, so I'm just going to pull this up on my working screen. So there's 1 provider, 1 assessor, 4 coordinators, 1 nurse, 28% or 28 individuals who are other. Interested to note who what that might entail. And then the majority of people aren't involved in MAID at all. Okay, if you want to put in the chat, those of you who indicated other, I'd be interested to know who else is in the crowd. Thank you for doing that. All right, so the history of MAID. How did we get here? So the conversation around assisted dying in Canada started at least in the 1990s, if not before that. Assisted dying in the world has been legal, specifically in Switzerland, since the 1940s. So it's actually been around for quite some time. But in Canada itself, the sort of first main point on our timeline here is in relation to the Rodriguez case, which some of you may be familiar with. So Sue Rodriguez was a woman from British Columbia. She had a diagnosis of ALS, and when it came to her realization that at some point she would lose the ability to make a decision about ending her life, or I should say the ability to end her life on her own terms, die by suicide. She really felt that it was the state's obligation to have somebody be able to help her to do that. So interesting to note that suicide was illegal, was criminally illegal up until the 1970s, I believe 1972. The criminal code changed to make dying by suicide no longer a crime. And so it was legal for somebody to end their own life, but Sue recognized that by virtue of her diagnosis, that would not be possible. And so she wanted assistance to do that. And so Sue took her fight through the provincial courts through British Columbia all the way to the Supreme Court of Canada in 1993. And the Supreme Court ruled in a 5-4 decision that there was not enough evidence and support to be able to institute this into or to remove the provision of assisting somebody with suicide from the criminal code at that time. And that, they were concerned at that time about the idea of a slippery slope and that there wasn't enough evidence in other jurisdictions across the world to be able to say that this could be done safely. They also felt that there really wasn't much interest or appetite within the Canadian public to make this decision. Although interestingly, the ruling was quite tight, 5-4. So, things could have been a lot different if a couple of those judges had voted differently. Sue Rodriguez did have an assisted death. An anonymous physician did help her to end her life. We don't know who that was, but she was able to avail herself of that outside of the law. But her court case sparked lots of discussion, and subsequently there were 6 private member bills that were introduced in the House of Commons over the 2 decades between 1990 and 2010. They were all defeated, but it goes to show that there actually was quite a bit of interest, enough for these private member bills to be introduced at the level of the House of Commons, that Canadians were interested in having access to this choice. In 2014, Quebec passed their Respecting End of Life Care Act. And I've spoken about British Columbia already. Now I'm speaking about Quebec. And as we go through the talk tonight, you'll see that those 2 provinces kind of come up a fair amount in the history of MAID. But basically this act in the province of Quebec kind of set the stage for the subsequent Supreme Court decision, which happened in 2015. And most people who have an awareness of MAID know that MAID stemmed from the Carter decision, so Carter versus Canada. And it's named after a woman, Kay Carter, who was also from British Columbia, and she had a diagnosis of spinal stenosis. She was only in her 60s, but had suffered for a number of years, decades, with chronic pain related to her spinal stenosis, to the point where she ended up traveling to Switzerland to the Dignitas Clinic, which is Switzerland is the only jurisdiction that allows non-residents to access assisted dying. And she traveled there with her family, her daughter and son-in-law, and died with an assisted death through that clinic. And upon return to Canada, her family really felt and they recognized what a privilege they had to be able to take Kay to Switzerland to allow her to have the death that she wanted. And they really felt strongly that in their mom's honor, that fighting for this right for all Canadians was something that they were willing to do. And so Kay Carter's family, along with another individual who her name is escaping my head at the end of a long day, it will come to me, who also had ALS and was also from British Columbia. They again took their fights through the provincial courts of British Columbia all the way to the Supreme Court of Canada. And at that time in 2015, the ruling came down unanimously. So all 9 judges ruled in favor of amending the criminal code to remove the prohibition on assisting a competent adult in certain circumstances, which we'll look at, to end their life. And interestingly, there was one judge who sat on both the Rodriguez decision and the Carter decision, Beverly McLaughlin, and she was able to speak specifically to the change that had occurred over the 20 plus years between the cases. And there were hundreds of pages of evidence from other jurisdictions worldwide that helped to support the notion that yes, assisted dying could be. Gloria Taylor came to me. There you go. Gloria Taylor was the British Columbia woman who had also had ALS. She interestingly died during the arguments of this court case of complications from her diagnosis. So she did not require an assisted death, but she was part of that fight. So back to what I was saying about Beverly McLaughlin, that there was lots of evidence to be able to say that yes, this could be done safely, and that the Canadian public clearly had an interest in having access to this. And so in February of 2015, the Supreme Court said, yes, we will amend the criminal code. Provinces and territories, you have 1 year to figure out how to implement this. And so in February 2016, the first case of assisted dying outside of Quebec, because Quebec had their own Respecting End of Life Care Act, and as we'll see later tonight, Quebec does things on their own timeline. So the first case outside of Quebec happened in British Columbia on February 29th, 2016. And that case actually was not as straightforward as MAID would end up becoming, because there was an election and there were a bunch of political concerns that came up that required the provinces and territories to ask for a 4-month extension. So actually from February until June of 2016, Canadians had to petition their provincial or territorial courts in order to access assisted dying, because the provinces and territories were 4 months behind on getting clinical practice up to date. So it was June 17th, 2016, on which the date that Bill C-14 passed. It was a momentous day. I was actually teaching my very first MAID talk in the undergrad palliative care course that I teach. So it was a pretty neat day for those students to be able to learn about this literally brand new component of practice. And so C-14 was the law that we practiced under. And eligible Canadians across the country were able to access assisted dying at that point. In 2021, there were further adjustments to the law, and those fall under Bill C-7, which is the current legislation that MAID is practiced under. And those changes stemmed from provincial court arguments, again, in Quebec. Jean Touchon and Nicole Gladue were two individuals who had cerebral palsy and post-polio syndrome. And they took their arguments to court that just because they were not going to die from their diagnoses did not mean that they were not suffering intolerably and therefore should not be able to access assistance to end their life. And the provincial court judge, Justice Jaudoin, she agreed with them. And the federal government decided to not challenge the decision that the provincial court had decided, and so ended up taking forward the changes and implementing C-7. And so those are the laws under which we practice MAID across the country today. So our current eligibility for C-7, some of these were also the eligibility under C-14, and we'll talk a little bit about sort of the nuances between the initial law and our current law. So in order to receive MAID, a person needs to be eligible for health services that are funded by the federal, provincial, or territorial government. And basically the rationale for that point is to avoid medical tourism. So you need to be a resident or in the process of receiving residency or healthcare within the provinces or territories of Canada. So refugees are able to access MAID. There are other classifications. You don't need to be a permanent resident, but you basically need to be living in Canada. You have to be at least 18 years of age and mentally competent and able to provide informed consent to receive MAID. So you need to have capacity. That's part of the assessment process. You need to be able to understand the choices that you have. That's part of being mentally competent. You need to make a voluntary request for MAID. That's not the result of outside pressure or influence. So again, that's part of the assessment process in determining whether somebody is making this decision on their own accord or whether there is external pressure. And they need to have a grievous and irremediable medical condition. And that sentence rolls off my tongue now, but 9.5 years ago, it was not something that we ever said in medicine. And so it's obviously a legal term and needed to be defined for us from a clinical perspective. So for a person to have a grievous and irremediable medical condition, they need to have a serious illness, disease, or disability. And for current practice, that cannot be a mental health diagnosis. They need to also be in an advanced state of decline in capability that cannot be reversed. And they also need to be experiencing unbearable, physical or mental suffering from either the illness, disease, or disability, or from the state of decline that they're experiencing that cannot be relieved under conditions considered acceptable to that individual. The other nuanced change, so if initially in Bill C-14, there was a requirement that an individual's natural death be reasonably foreseeable, and that was the eligibility criteria that Jean Touchon and Nicole Gladue took their argument to courts about. And so in C7, this was changed, that reasonably foreseeable natural death was no longer an eligibility criteria, but rather it was what was used to determine which track a patient was considered, and therefore which safeguards needed to apply in order for the patient to access MAID. The determination of which track a patient belongs to is actually the sole responsibility of the MAID provider. So no coordination service or assessor makes that determination. They may have conversations and may provide insights and information in helping the provider to decide, but it also ultimately the responsibility falls to the provider. So I'm not going to go through all the safeguards because they don't all apply to the content of our talk today, but just wanted to highlight that many of the safeguards apply to both track 1 and track 2 patients. So for both these tracks, patients have to undergo 2 independent assessments, and the 2 assessors, the 2 independent practitioners, need to confirm that all eligibility criteria have been met. The individual needs to make a written request that is witnessed and signed by 1 independent witness, which, and this is a change from C14 to C7, can be a paid caregiver. C14 used to require 2 independent witnesses, neither of whom could be a paid caregiver, and that clearly was impeding access to MAID. The person, track 1 or track 2, must be informed that they can withdraw their request at any time by any means. And for both, immediately before MAID is provided, the person must be given opportunity to withdraw their consent, and they must confirm consent in order to receive MAID. Specifically for track 1, immediately before MAID is provided, the person must be given opportunity to withdraw consent and confirm consent to receive MAID, unless they have a final consent waiver, also referred to as an advanced consent. So this was a change with C7, and it allowed individuals to avoid needing to be competent at the time of MAID provision in order to move forward with the procedure itself. So advanced consent is made up of two different approaches. The first is a final consent waiver, as it's worded in the law, and the second is advanced consent for failed self-administration. So the final consent waiver is also colloquially known as assessed and approved, or Audrey's amendment. Audrey is Audrey Parker. She was a woman from Nova Scotia this time, other side of the country, making some inroads in MAID law progression. She was a woman with metastatic breast cancer. She had mets to the meninges, the coverings over her brain, and she was very, very concerned that she would lose the capacity to consent to MAID, even though she clearly met the eligibility criteria and had been deemed approved for MAID. She described that Christmas time was her favorite time of year, and she would have loved to live through another Christmas and to have MAID after the season was over. But she really was more concerned about her loss of capacity, and so ended up having MAID in November so that she could still give the final consent to receive the procedure itself. And so after she died, her friends took up her cause and lobbied for this change to be made with the new change in the law in 2021. And so they were successful. And so the waiver of final consent applies only to track 1 patients, so those whose natural death has become reasonably foreseeable. They need to have met all MAID eligibility criteria prior to the loss of capacity. So the loss of capacity cannot be the thing that causes them intolerable suffering or be the decline in capability. They have to have met all of the criteria prior to the loss of capacity. They need to be informed by the provider that they are at risk of losing capacity to consent to MAID, and that loss of capacity can be for any reason. So it may be in relation to increased analgesia or pain medication requirements. It may be because of illness progression, like in Audrey's case. It may be because they're at higher risk of falls or trauma to their head that would rob them of capacity. So it doesn't have to necessarily be related directly to the diagnosis for which they're seeking MAID. They just need to be at risk for losing capacity. And so if those criteria are met, then a patient and their provider can enter into a written arrangement that may be provided on or before a specified day. And so the written arrangement needs to include the name of the practitioner or the person who's going to provide MAID, and if there are alternative providers, so if there's a group of providers that work together, they can have different waivers associated with each of those providers. But though each provider needs to have assessed the individual and determined their eligibility independently. So the name of the provider, the name of the patient, the date that MAID is to be administered on. So patients need to choose a date for MAID. And it needs to state that the patient explicitly consents to the administration of MAID on that date or before if they lose capacity. So the consent for the procedure is contained within that written arrangement for the provision of MAID if the patient's capacity is lost. If capacity isn't lost and the patient is capable of giving consent on the day of the scheduled provision, then that is what we do. We get the verbal consent, but this is a way to ensure if that's lost, we can still move forward with the procedure. There is a caveat, though, that if the patient demonstrates resistance or refusal at the time of the procedure, then MAID cannot go forward. So this does not include involuntary words, sounds, gestures made in response to contact, so placement of the IV, flinching, that kind of thing. But if an individual loses capacity and is quite confused and is averse to care and says, get away from me, I don't know what you're doing, I don't want this, that is refusal. And so the provider is not able to move forward with the provision at that time. And if a patient gets to a date that's specified in a waiver and they actually don't want to have MAID that on that date any longer, they can obviously opt out of having MAID on that date. But if then they subsequently want to extend that timeline to another week, another 2 weeks, however long, they need to enter into another arrangement, another waiver with their provider. So you can't just cross out the date and put a new one in. The other type of advanced consent is failed self-administration. I'm not going to speak to this really at all, other than to say that it's available. We've had 3 cases of oral MAID since legalization in 2016. So it's not something that's done very frequently. There are many good reasons behind that, but basically if the oral administration fails to end somebody's life in a specified time frame, the patient can enter into an agreement prior to obviously ingesting the medication that would allow the provider who's present to initiate intravenous lines and to administer MAID at that time on behalf of that individual. In other provinces, they have a few more oral MAID cases, and a number of them have ended with transition to intravenous MAID because of the conditions of the failed self-administration document being met. Okay, so we're going to test your understanding of all of that information. So we got a case study. So Susan is 67 with primary lung cancer with metastases to her brain, her adrenal glands, and her bones. Her disease has not responded to chemo, immuno, or radiotherapy. She's followed by the palliative care team, but she also wants to be assessed for MAID. She is currently a palliative performance scale of 50% with well-controlled symptoms. So, as a provider, do you offer Susan a waiver of final consent at this time? Yes, no, or I don't know yet. Recognizing that most of you are not providers, what would you do in this circumstance? What do you think? What should the provider do? Okay, interesting. So yes, 36% said yes, we should offer Susan a waiver of final consent. 30% say no, we shouldn't. And 34% I don't know yet. So we're evenly split. That is very interesting. Okay. So, according to the Canadian Association of MAID Assessors and Providers, guidance on the use of waiver of final consent document that came out in September 2024, they specify that the purpose of the waiver is to protect access to MAID provision for those who are already eligible. And it's not to be used as an advanced request for MAID in the future. So the final consent waiver is not a request for MAID, but rather a tool to provide an advanced consent under very specific circumstances, as we've reviewed. So they also recommend that all the elements of proceeding under a waiver should be clearly documented. So as a provider, if I were to move forward with provision of MAID, invoking the waiver, I need to document the loss of capacity. And if there were any other stipulations within the waiver that needed to be met, sometimes people will include things like making sure their specific family members are present. Then I need to be able to document that those things were met before I proceeded with MAID. And then they also talk about the fact that the waiver of final consent can be completed after only one eligibility assessment. So the patient could be assessed by one assessor. That assessor determines that they meet all of the eligibility criteria. They are going to be the provider for that patient, and they enter into a waiver of final consent agreement with that patient, just holding out that the other assessor still needs to do their assessment, and obviously the waiver can't be invoked until that second assessment has been completed. So there is no legal reason why a waiver can't be signed after an initial assessment pending the second assessment. Having said that, the MAID Death Review Committee here in Ontario, and I'm going to read this verbatim, suggests that MAID practitioners should confirm, communicate, and document eligibility for MAID prior to evaluating a risk of loss of capacity and entering into a written arrangement to waive final consent. So basically, they need to have done their eligibility assessment independent of the fact that the patient may want a waiver, and then look at, okay, this patient is eligible for MAID. Are they at risk of losing capacity before their provision? And they say that this approach to practice ensures that the eligibility criteria related to the ability to make healthcare decisions is confirmed. So they're able to make a decision about MAID and understand their options prior to the person's anticipated loss of capacity. And they also say that this is also in alignment with professional guidance, as this approach reduces the perception that the eligibility for MAID is being applied to future circumstances or conditions, and approach more in keeping with an advanced request. So basically, MAID assessment should occur separately from an assessment of whether a waiver of final consent is appropriate or not. And I think what they're really speaking to is that loss of capacity, that prior to the loss of capacity, the patient was eligible for MAID. They then lost capacity, and therefore the waiver was invoked. Okay, another poll. The date on a waiver can be no more than a week away, no more than a month away, no more than 90 days away, or there is no time limit specified in the law. Give you a minute with that. And we will come back to Susan. I didn't mean to leave everybody hanging with the evenly distributed a third, a third, a third. We will come back to that.
The tricky thing I find with that first question was the offering a waiver of final consent as part of that process.
Yep. That's a fair point, Val.
Okay, people are really thinking about this question, so I'm gonna give it another.
I'm not surprised. Trying to rack their brain and think, have I ever heard one of these before? And I didn't give you an out. You have to pick one. Okay. All right. So one person said no more than a week. 6 people said no more than a month. 17 said no more than 90 days. And 45 said there's no time specified in the law. And the majority are correct. There is no time limit specified in the law, except if you're in Quebec. And in Quebec, the limit is 90 days. So vast majority of you guys were right. But for those of us outside of Quebec, there is nothing in the law that says a waiver can't be for 6 months, a year out. There are sort of some nuances to practice if that were to be the case. I'll share in my own individual practice. If I have a discussion about a waiver with a patient, it is in the context of a patient wanting to have MAID on a specified date, not that they're wanting to have MAID at some point in the future and they will pick a date to put on a waiver to preserve their capacity or to preserve their access to MAID in the setting of loss of capacity, but rather they want to have MAID on a certain date, and in that intervening short time frame, likely days to weeks, they may lose capacity for whatever reason. But there's nothing in the law to say that that's how it has to be done. So things to consider before discussing, or as Val pointed out, the term offering a waiver of final consent. So capacity is task specific. So a patient may have the capacity to consent to MAID. So capacity involves understanding their circumstances and appreciating the options that they have. So somebody may have the capacity to understand that in relation to MAID, but not the capacity to understand and agree to the more complex concept of a waiver. So a waiver is talking about in the future, if this happens, I would still want MAID to happen. And so they need to understand that, if they lose capacity, somebody will have to notify their provider that loss of capacity has happened, and that they need to choose a date. And for some people that, earlier on in their trajectory is not something that they're willing to contemplate or think about at that time. The other thing that's really important to consider before discussing a waiver is who will be the person responsible for communicating the loss of capacity to the MAID provider. MAID is always a discussion between a provider and a patient, and it's always the patient's decision to proceed with medical assistance in dying. But when a waiver is brought into the conversation, it also brings in a third party. Now, that person is not making a decision about MAID, but they are informing the provider that the patient has lost capacity. And for some individuals and families, that is just a bit too much. They may not be able to bear that idea that they, from their perspective, instituted or started the MAID process that ultimately ended in the death of their loved one. So making the call to the provider to notify about loss of capacity is just not something that all families are capable of doing. And in that case, it may not be appropriate to have a conversation about a waiver. It's also important to clarify that signing a waiver does not guarantee that MAID will happen. So we are, as providers, are never obligated to provide MAID, and both the patient and the family need to be aware of this, and specifically the family. So I often find when MAID, for whatever reason, becomes unavailable, either because there was no waiver signed or things change really suddenly, it's the family that has to come to terms with that. So if a patient has been adamant that MAID is what they wanted and they just haven't set a date, and then they lose capacity and they're not able to have a MAID death, the family is the ones that have to come to terms with that. And so understanding that even with the waiver of final consent, which is a way to help avoid that type of situation, it's not always possible for MAID to happen. And the way I kind of talk families through that is by pointing out that the whole purpose of MAID is to end suffering. And if this individual has lost capacity, in most circumstances, that loss of capacity is very closely followed by natural death. And that also will end their suffering, right? And so if what we want as people who care about this individual is for their suffering to be over, we know, regardless of MAID or not, that their suffering will soon be over. Providers aren't always made aware of loss of capacity in as timely a fashion as they need to. Even when they are, there are logistical concerns like getting IVs placed, getting medications from pharmacies, availability of providers. So all of those things factor into having conversations about the waiver and helping people to understand that it is not a guarantee that they will get MAID even when they do sign a waiver. And again, the patient can change their mind at any time, including at the time of MAID provision. And so that also adds in a level of complexity, because if a the date on their waiver comes up, they have the capacity to say, I don't want to die today or tomorrow on the day that my waiver expires, but they are ill enough that they've lost the capacity to understand what signing a new waiver entails and choosing a new date, then for them to say no to MAID today may mean that they can't have MAID in the future because they've lost the capacity to enter into another waiver agreement. And so patients need to understand that when they're putting a date on their waiver, that should ideally be the date that they are ready to have MAID, not some arbitrary date in the future, at which point they may have lost capacity to sign a new waiver, but maintain the capacity to say, no, I don't want to die today. Okay, so let's go back to our case with Susan and see whether any of that additional information has sort of changed your opinions and your approach. So Susan, remember, she's 67, she's got metastatic cancer. In this version of Susan's case, she's not 100% sure that she wants to die by MAID. She would be okay dying naturally if her symptoms were well controlled. Her daughter, who Susan is living with and who's providing her personal care, adamantly does not agree with MAID, and she voices this disagreement regularly. So in this case, as a provider, do you offer Susan a waiver of final consent at this time? Yes, no, or I don't know. Okay, so 21 people said yes, they would offer Susan a waiver of final consent at this time. 39% said they would not, or 39 individuals, excuse me, and 12 individuals said they don't know yet. So I will share with you as a provider, I would not discuss a waiver with Susan at this point. She knows that MAID is available. She's eligible for MAID. She can make a decision about MAID when she's ready, but she would also be okay if she died a natural death without having MAID. There are many people who enter into the process of MAID to have it as an option that ultimately do not have a MAID death and who die a natural death with good palliative care and good symptom control. The other sort of red flag in this case is that her daughter is not supportive of MAID. And by virtue of the fact that Susan's receiving personal care from her daughter, it would likely be that her daughter would be the one to be aware of her loss of capacity. And with her daughter not being supportive of MAID, I'm not sure that that is the right situation to put her in. And so, I would explain those things if Susan and her daughter brought up a waiver of final consent, although I doubt her daughter would. But in this circumstance, I don't think that this is an appropriate use of a waiver for somebody who's not sure that they want to actually have a medically assisted death. Okay, what about this circumstance? So same Susan. Now she's experiencing a lot of dyspnea and she has required increasing doses of hydromorphone. She's also become more confused and she's having word finding difficulty. She knows that she wants to have MAID after her birthday on November 23rd, today being October 30th. Her daughter, who Susan is living with and who is providing her personal care, absolutely agrees with her mom's choice for MAID. So, as a provider, do you offer Susan a waiver of final consent at this time? Yes, no, or I don't know yet. Okay. All right, so 66 people said yes, they would offer Susan a waiver of final consent at this time. 7 people say no, they would not, and 3 say they don't know yet. Okay, awesome. So again, in my practice, this is a circumstance in which I would offer a waiver of final consent. So she's got a couple of reasons why her loss of capacity is at risk. She's on increasing doses of opioids, which definitely could have an impact as doses escalate on her capacity and her wakefulness. She's also having some symptoms that could possibly be related to her metastatic disease with confusion and word finding difficulties. So we don't really know what's going on in her brain, but that could definitely result in loss of capacity. And she has a time frame for her death planned out. She wants to die after her birthday, which is a couple of weeks from now. So for me, as a practitioner, as a provider, I would be very comfortable entering into a waiver, especially knowing that her daughter is supportive of her decision to access an assisted death. So I just want to put a caveat on that there are no right or wrong answers here. You would not be wrong to have offered Susan a waiver at the very beginning without additional information. You wouldn't be wrong to not offer Susan a waiver in the last scenario. It's really just to provide some examples of some of the things that as a provider I think about, and I know my colleagues think about when they're considering which patients make sense to have a waiver. So last word on waivers. As I just said, providers have perfectly valid reasons for differences in the way that they use and apply waivers of final consent. And some of these depend on the provider's location and their pattern of practice, their regional manpower issues. So, if they're a lone provider who's responsible for providing MAID for a number of patients, or who, they only do MAID for their own patients, and it's a very small caseload of patients, or they don't have a whole lot of experience doing MAID. They've only done a few cases and they haven't involved waivers. Their own practice history and their own pragmatic and ethical comfort in their use. So as I've described, my own practice is a practice that I feel comfortable instituting based on the fact of how I read what a waiver is meant to be and the circumstances in which it's meant to be instituted. But that may be different and I know it is different for other colleagues in their practice. And the individual cases themselves, as we've seen with Susan and the different iterations of her case, the challenges that are posed by individual patients and their circumstances are going to have an impact on whether a waiver is brought up and signed with a patient. And these points are paraphrased from a colleague of mine, Dr. Richard Scott, who is a doc in Ontario, and we had extensive posts on waiver of final consent, so I have utilized his wisdom in this presentation quite a bit. But he was also a member of the guidance document that CAMAP put out that I referenced earlier. So and the last thing I'll say about waivers is that ideally, this is a conversation that is happening between the provider and the patient. And it really shouldn't be something that is discussed as a possibility by anybody other than the provider, who may be the person who administers medical assistance in dying to this particular patient. So even as a secondary assessor, I don't bring up waivers of final consent with patients and families for individuals who I wouldn't be providing MAID for. I may tell the provider, this might be a patient that you want to discuss a waiver with. They had some questions about it, or I have concerns about loss of capacity, but ultimately it should come down to the provider making that decision. Okay, so we're going to pause for some questions.
Yeah, so Janice was asking about resources to support people who are making the decision about medical assistance in dying. And in particular, if somebody had a history of trauma that could be affecting how they're making the decision, are there resources available to support them beyond, the clinicians that are supporting them as part of the assessment or being a provider?
Yeah, so there are organizations that can help patients and families through the MAID process. The MAID family support hold on, I'm just gonna pull my handy cards that I give to patients and families at a provision. So MAID Family Support Society is a great one. They are made up of individuals who have lived experience with MAID, so family members of people who have died from MAID, to be able to support both the patient and the families pre, during, and post MAID provision. And then Bridge C14 is another organization that helps to support through all stages of medical assistance in dying. And then Canadian Virtual Hospice has good resources for the bereavement period, but the Bridge C14 and the MAID Family Support Society would be the two that I would recommend for supporting patients and families as they journey through the process.
Awesome. I'll put those links in the chat there.
Thank you.
Somebody had quite a specific question. So I am asked if I'm a secondary assessor and I'm asked about waiver of final consent, do I say it's up to the provider?
I would default to them. Yeah. So if you're a secondary assessor, as I said at the end, that when I'm in that position, if a patient or family asks me about it, I may give sort of a high level explanation of what a waiver is, but I will let them know that that's a conversation that's best had between them and their provider. And if we know who the provider is at that time, then I will, as a professional courtesy, reach out to them and give them a heads up that this patient and their family were asking about a waiver. And if I had any, red flags or things that, would be supportive for them to know about having that conversation with that particular patient and family, then I would share that with them as well.
Somebody asked, working in a hospice setting where MAID is provided, if a patient has a waiver of final consent signed and the patient loses capacity and has a low PPS, is it up to the family or the nurses to inform the MAID provider that their status has changed?
There's nothing specifying that either in the law or in the waiver documents that I've seen. It really can be anybody. I think in that circumstance, I would approach that as, saying to the family, I've noticed that your loved one is changing, and I'm concerned that maybe, they might be at a point where we should let the MAID provider know that, they haven't woken up, or they're at this level of PPS or function, or these are the changes that you've seen, and just sort of ensure that everybody's on the same page. I don't think it's necessary for the staff to sort of go behind the family's back and let the provider know that these have happened, that this change has happened. But I think it would be helpful, as I say this quite often, as somebody who's journeyed alongside many people at the end of life, I've seen what's happening before. And so using your skills in that setting to let that family know that this is a circumstance that we've reached now where we're letting the MAID assessor or MAID provider know in order to help make a determination of what the next steps would be important. It obviously may be sort of a more touchy conversation if they haven't been supportive of MAID. And then I would, default to letting the provider know that things are changing and that maybe having a conversation with the family is something that they might entertain.
Somebody picked up in the case that you mentioned that Susan is intermittently confused.
Mm-hmm.
How could she be offered a waiver in this case?
So intermittent confusion does not remove your capacity to make decisions. So she may have times in the day, later in the day when she's more tired and less able to sit and have a conversation and contemplate what a waiver might be. But just because somebody is having moments of confusion does not blanket limit them having a conversation about a waiver of final consent.
And I think he kind of answered this one, but if you just maybe confirm, do you routinely talk about the waiver or only if the patient asks? Sounded to me like it's kind of context specific.
Yeah, exactly. I don't wait for the patient to ask because not everybody knows that this is something that's available. But if what I'm hearing from the patient is that, you know, they want an assisted death, that is the thing that is most important to them, or they have a date and they know that they want to die, you know, on this date, or you know, we've had to make adjustments to their medications for whatever reason, or they've had recent falls and you know they're likely going to have more. Any or all of those sort of circumstances within a patient's situation might prompt me to have a discussion about a waiver. I think the biggest thing when talking about a waiver comes down to having to choose a date. So if a patient is not capable of, as far as emotionally capable, not cognitively capable, but looking at a calendar and saying, yeah, that's the day, then a waiver isn't something that I would feel comfortable entering into.
Just based from your personal practice, like how often does it happen that somebody has done the waiver of final consent and then, you know, the day comes and they decide not to proceed with MAID?
I have never had that circumstance, but I don't sign a lot of waivers because of the circumstances that I sort of have for moving forward with a waiver. I don't know the answer to that across the board. I think it would depend on individuals' practices and how many waivers they're signing and how they approach waivers. So colloquially, we talk about in the MAID community rolling waivers. So patients who, you know, pick an arbitrary date in 3 months, they get to that date, they're still feeling really well, they still have capacity, they sign another waiver with their provider for 3 months out. That is not illegal. That is how some people approach waivers for certain patients because their practice allows that. They're able to follow patients for extended lengths of time. The patient already met the eligibility criteria for MAID, but they're doing really, really well to everyone's surprise. Like there's so many nuances to it. So it doesn't, it's not that it doesn't happen, but you know, it would be very specific circumstances in which somebody would get to the waiver date and say, no, I'm not ready, let's do this again. In my practice, the way I use waivers, unless the patient is basically saying, I've changed my mind and I don't want to have MAID, I couldn't foresee that happening because they have said this is the date and they are ready for that date.
And then there's just one more about just the assessments in general, aside from the waiver conversation. How long are the assessments valid? If somebody's been assessed by 2 assessors, they've been deemed eligible, what is the length of time that those are valid?
Forever, technically. There is no legal expiry date. But I explain to patients, you know, there's no pressure for you to move forward with this at any point. But if it's been a reasonable amount of time, a fair amount of time, and I don't put a specified length of time on this caveat that, you know, I may want to come and see you again to see what's happened, what's transpired in the in-between. We know that and data supports that undergoing the MAID assessment process and knowing that you have this available to you can often be a hugely therapeutic intervention in itself. And so it does allow people to go on and live at a better quality of life for longer than they anticipated. And so there's nothing wrong with having gone through the assessment process and wait until you are ready to proceed or not proceed. But I also think it is not wrong for providers who are doing this work to say, wow, I haven't heard from you in 6 months. Like, what's happened since then? So they can document and say, you know, yeah, I found them eligible then. They've done this. This is what's happened. Now they're at this point, which is worse than where they were at before, and they're ready to proceed with MAID. So it's really about that longitudinal follow-up and being able to sort of show what's happened in the interim, and less about sort of the assessment expiring.
Right.
Anything else for now?
Head on for now, I think.
Okay.
Yeah.
Sounds good. Okay, to another poll. So an advanced request is a final consent waiver, an advance directive, advanced care planning, only legal in Quebec. There's only one answer. I imagine many people will be thinking over all of these words because on the surface are they not all the same thing? Okay. So 12 people say an advance request is a final consent waiver. That is not right. 24 people said an advance request is an advanced directive. That is not right. 14 people said an advanced request is advanced care planning. That is not right. I can see why you would think that. 18 people said it's only legal in Quebec. That is the correct answer. It is only legal in Quebec. So an advance request is not a waiver of final consent, because a waiver of final consent, as we've learned, is when somebody is already eligible for MAID and they are setting up provisions to ensure that they have access to MAID if they lose capacity. An advance directive is something that's specific to different parts of the country and other parts of the world that lay out medical care that you would be willing or not willing to undergo should you lose capacity. So they are specific to medical care and cannot at this point include an advance request for MAID. Advanced care planning, I guess that was kind of a trick question. Yes, an advance request could be part of your advanced care planning conversation if you are in Quebec at this point, but it isn't actually advanced care planning. It's something separate. It's an advanced request specifically for MAID. And yes, it's legal in Quebec. The criminal code has not changed in Quebec, but Quebec has put in provincial provisions to allow for advanced requests. So interestingly, as I was reviewing this presentation yesterday for today, I realized that actually it became legal in Quebec 1 year ago today, October 30th, 2024. So an advance request allows a person to give their consent in advance to receive medical aid in dying in the future under certain conditions when they will no longer be able to consent to receiving aid. So these next few slides are taken from the Quebec government site, specifically about advance requests. So just keeping in mind that we're talking about Quebec. If you don't practice in Quebec, this isn't legally available. But to help to differentiate what an advance request is in comparison to a waiver of final consent. So I'll talk specifically about the parts that I've highlighted. So with a lot of the requirements or eligibility criteria, I should say, for advance requests in Quebec are very similar or the same as eligibility criteria for MAID in general, except for the first point here that a person, an advance request can only be made by a person who has been diagnosed with a serious and incurable illness that will lead to incapacity to give consent to care. So a patient, in order to write an advance request for MAID in Quebec, they need to already have received a diagnosis that will lead to loss of capacity. But they don't need to yet be in a state of irreversible decline, incapability, or suffering intolerably at the time that they make the advance request, unlike a waiver of final consent, where you need to have met all of the eligibility criteria for MAID, including being in an irreversible decline in capability and suffering intolerably in order to enter into a waiver of final consent. And then the last point, that advance requests will not automatically lead to the administration of MAID. So just as we talked about with the waiver of final consent, just because a document is signed does not mean that a provider, in this case, years down the road, will be obligated to provide MAID for you, despite your best planning. To receive MAID by an advanced request, which to my knowledge has yet to happen, the patient needs to continue to have that serious and incurable illness that is leading to incapacity to give consent to care. So they have continued on their trajectory of Alzheimer's dementia, and now have gotten to a point where they are incapable of giving consent to care due to their illness. So Quebec specifically lays out that the loss of capacity needs to be linked to progression of their illness. They also need to be exhibiting on a recurring basis the clinical manifestations related to their illness and described in their request. So at this point, the person is likely to have a decline in capability and to be suffering intolerably in the ways that they have determined when they were drafting their advanced request. And then also to receive MAID, the patient needs to be in a medical state that gives a competent professional cause to believe, based on the information at their disposal and according to their clinical judgment, that the person is experiencing enduring and unbearable physical or psychological suffering that cannot be relieved under conditions considered tolerable. So this point gives a fair amount of power and subjectivity, I should say, to the assessor in determining whether this individual is experiencing enduring and unbearable suffering, which is not something that is a part of a part of a final consent. So this idea of contemporary suffering as a clinical evaluation. So when you're today creating an advanced request for years down the road, when your dementia has progressed to a point where you're no longer able to give consent to your care, you are required to think about what is going to change between now and then that is going to be, one, related to your dementia diagnosis, and two, is going to be observable by a healthcare provider. And that's where the creation of the advanced request really becomes the most important step in being able to detail what those criteria are for this patient in relation to the specific disease, and that will be objectively observable by another person. So they need to be medically recognized as being clinical manifestations related to that specific illness and observable by that competent professional. So examples might be when an individual gets to a point in their dementia where they're unable to feed or toilet themselves for a period of time, when they're not able to recognize their family members for a period of time, when they become aggressive or start exhibiting behaviors, psychological symptoms of dementia or BPSDs. Those may be things that somebody includes in their advanced request as evidence that now they're at a point in their disease where they're suffering intolerably and in an advanced state of decline. And then at the time of MAID provision, the law in Quebec requires that the patient be exhibiting on a recurring basis those clinical manifestations, but it doesn't specify what that time frame is. So it's recurring, but over what time period. And then it also gives the competent professional this sort of leeway or as I use the term power in determining whether this patient is experiencing enduring and unbearable physical or psychological suffering. So although a patient may say when they're writing their advanced request, these are the things that I deem to be suffering, the clinician is ultimately the one to determine, one, whether the patient is exhibiting those clinical manifestations, and two, whether the patient is then experiencing enduring and unbearable suffering from those said clinical manifestations. So we have yet to see how this will play out, because as I say, there have been no provisions of MAID from an advanced request. There have been requests drawn up, but nobody has had MAID with an advanced request yet. And so I was part of a working group through the Canadian Association of MAID Assessors and Providers that created a document called Clinical Considerations for Advance Requests for MAID. And we did a presentation at the CAMAP conference in Ottawa in 2024. And the goal of the document wasn't to necessarily, was not definitively to set out recommendations about how to implement advanced requests for MAID, but rather to highlight some of the concerns or some of the things that we needed to consider within the clinical practice of advanced requests. We know definitively that Canadians are in support of advanced requests, but I know for myself in speaking with lay people, their understanding of the nuances of how this would roll out in practice is less sort of worked through than I think it will need to be in order for this practice to come actually become available for Canadians. So some areas of concern that the working group looked at were this idea of objective versus subjective suffering. Who is making that determination? How is that possible if the individual who is suffering is no longer able to say that they are suffering? The fact that the Quebec law talks about disease-related behaviors, so they need to be specifically related to the diagnosis and not necessarily to other aspects of an individual's medical conditions. There needs to be a diagnosis required, and whether that is actually meeting the desires and needs of Canadians by requiring that in order to write an advance request. In Quebec, they have a concept called the trusted third person, and it's actually not a requirement, it's a recommendation that there be a trusted third person who is able to alert the a MAID provider, the repository where these advanced requests are housed within Quebec, to reach out and say, I think that this person is exhibiting the criteria within their advanced request, and I think they need to be assessed by a MAID provider. So the Quebec law has suggested that individuals creating an advance request identify who that person is going to be. How does that work? If you don't have somebody who you can identify as that, if your trusted third person dies before you do or becomes incapacitated in some way, then who takes on that responsibility? And then I think one of the things that sort of starts this conversation from a philosophical perspective is the pleasantly demented individual, or Margot, as she's often referred to in case studies, who is completely happy sitting in front of the TV watching Sesame Street with her baby dolls, and loves sitting in the dining room and having lunch with her friends, but prior to reaching this stage in her dementia was, an academic who was very learned and would have looked at this version of herself with horror. Is Margot suffering if she is no longer that person, right? So these are just some thoughts that I think are worth reflecting on. And so I'm going to get you to do some polls and reflect on some of these. So the first poll is, should a diagnosis be required to complete an advanced request for MAID? Yes, no, or maybe. And again, there's no right or wrong answer to any of these questions. They're more just getting you to think about things that maybe you haven't contemplated before. Okay. So 55 people say yes, a diagnosis should be required. 9 people say no, and 13 people say maybe. Okay, interesting. So there's basically 2 broad categories when you think about having a diagnosis. So obviously people who are diagnosed with a progressive predictable condition that's going to lead to the loss of capacity, like Alzheimer's or other types of dementia. And then there are other people who are worried about a sudden, unpredictable condition that will lead to a loss of capacity, like a severe stroke or an accident. And the idea of having a diagnosis means that we know there's a somewhat predictable trajectory to the loss of your capacity, but a sudden unpredictable condition means that we don't know who out of the population is going to necessarily experience such an event, right? Yes, we can, with some level of accuracy, say who is at higher risk to have a stroke, or who might be at higher risk for an accident if you partake in high risk activities as part of your hobby. But we don't know whether I'm going to get hit by a car tomorrow, right? So should I be allowed to, or legally able to, enter into an advanced request now, knowing that I have no higher risk of losing capacity down the road than anybody else? So it's an interesting thing to think about. And so at this point in Quebec, and also the Special Joint Committee on MAID that did make recommendations in their February 2023 document for the government to consider advanced requests. Both Quebec and the Special Joint Committee discussed advanced requests only for Category 1. So only those people who have a diagnosis that will lead to loss of capacity. But interestingly, 71% of Canadians polled by Dying with Dignity in 2024 support having access to advanced requests for Category 2 as well, so sudden loss of capacity. And in a timely turn of events, the National Conversation on Advanced Requests for MAID report that stemmed from conversations and roundtables that were had, I believe, from November last year to February of this year about advanced requests. The report just came out yesterday. So I was able to include some of the data from that. And it showed that 68% of respondents support advanced requests for Category 1 and anywhere from 58 to 76% for Category 2. So they had different breakdowns based on whether it was roundtables versus questionnaires versus random telephone polling. So, I mean, they're not too far off. It's still generally around the 70-ish%, 60 to 70% for advanced requests. But that's a decision that will ultimately need to be made by the government, whether this is something that is only for a certain subpopulation of people who definitively will lose capacity, or whether this is something that can be implemented for everybody in the one-off case that you do lose capacity in the future. Okay, next poll. Intolerable suffering as a criteria for MAID should be defined by the requester's subjective and objective views only, so the person making the advanced request, the assessor, so the nurse practitioner or physician, their subjective and objective views only, or a combination of the two. Okay, so 20 people say that intolerable suffering should be defined by the requester's subjective and objective views only. Nobody agreed that the assessor should be determining intolerable suffering alone. And 54 people felt a combination of the two, of the requester and the assessor's subjective and objective views should be taken into consideration. So, interestingly, the Quebec law is currently only B. So it is the assessor's subjective and objective views only. They are the person who determines ultimately whether the individual in front of them is suffering intolerably. The requester can put forward, these are the things that I feel I would, the circumstances in which I feel I would be suffering intolerably. But if the assessor then sees the patient and determines that, in fact, from their perspective, this individual is not suffering intolerably, that is the decision. So, for example, Margot, the pleasantly demented person, would likely not be found eligible under an advanced request because subjectively by the assessor, she is not suffering. She is pleasant, she is happy, she smiles, she laughs, she has enjoyment in her life. She is not intolerably suffering. So the working group recommended that a standardized approach to identifying and documenting suffering is a crucial part of drafting an advance request, and that the advance request ought to detail the specific circumstances and objectively accessible measures of suffering as defined by the requester. And then those should take into account considering the entirety of that individual's experience, including physical, emotional, and existential factors. Identifying the objectively accessible indicators of suffering will be the role of the assessor, but the determination of what qualifies as suffering ought to be defined by the requester when they're drafting their advance request. And it should not be up to the assessor to determine that, in fact, that thing is suffering, that experience is suffering now, if it is laid out in the advanced request by the individual prior to. So that is contentious and confusing for sure. Okay, let's look at some specific situations. A patient meets all of the eligibility criteria for MAID under an advanced request, but is aggressive and resistant to all care. What should the MAID provider do? A, not provide MAID, as, quote, any refusal expressed by the patient must be respected, and it is prohibited to disregard this in any manner. B, determine, using their clinical judgment, whether this refusal is specifically to MAID, and if it's not, then proceed with the provision. C, ensure that the patient will receive the sedation that they consented to in their advanced request prior to their planned provision. Or D, not get into this situation in the first place. I was nice and gave you an out.
Okay, I'm gonna give this a little bit longer here. I see there's
lots of words.
Yeah.
Okay, I'm glad only one person chickened out in answering. When we did these polls at the CAMAP conference, it was really, really interesting to see the discrepancies. It was pretty eye-opening. So in this case, 34 people said not to provide MAID, as any refusal expressed by the patient must be respected, and it's prohibited to disregard this in any manner. The same number, 34 people, said determine, using their clinical judgment, whether this refusal is specifically to MAID, and if it's not, then proceed with the provision. And only 7 people said ensure that the patient will receive the sedation they consented to in their advance request prior to provision. So a meaningful refusal of MAID or any medical procedure or any care in this patient's situation requires capacity in order to make an informed decision. So if the requester meets MAID eligibility under an advance request, then they've lost the capacity to make decisions regarding MAID, right? They've lost the capacity to make that decision, which is why we are assessing them for possible MAID provision, because now they've lost capacity. Our suggestion was that people need to consider the real possibility that their disease progression may lead them to this state. This is how some patients with dementia present. They are aggressive and resistant to all care. No matter how great your clinical skills are, it will be impossible in this situation to determine whether this individual is resistant to MAID or resistant to all care. It would be almost impossible to make that determination. And so thinking about this as a real possibility by virtue of the diagnosis that they've been given, they may want to consent to the administration of sedation prior to the procedure in order to avoid a situation in which they refuse and that provider takes that as refusal and does not feel comfortable moving forward with a MAID provision. It's obviously going to be important to include family, friends, substitute decision makers, anybody who is supporting this individual in understanding the nuances of this potential situation, and that sedation may be something that best meets the patient's needs in allowing them to have a medically assisted death at this point in their disease process. Okay, what about in this situation? I think this is our last poll, so bear with me. A patient meets all the eligibility criteria for MAID under an advanced request, but appears very happy in their current state, despite having identified said state as constituting intolerable suffering when drafting their advanced request. So patient said, I don't want to be like Margot, that would be intolerable to me. But here we are, they've met the criteria under their advanced request and they've lost capacity. What should the MAID provider do? Not tell the patient what they're doing, and if the patient asks, dodge the question. B, ensure that the patient will receive the sedation they consented to in their advanced request prior to the planned provision. C, ask the patient if they want to have MAID today and proceed based on their answer. Or D, not get into this situation in the first place.
I see there's a few people still answering here, so last chance.
Okay, so nobody said that we should not tell the patient what we're doing and dodge their questions if they ask any. 25 people said that the patient should get the sedation that they consented to in their advanced request. 48 people said that we should ask the patient if they want to have MAID today and proceed based on their answer. And 3 people opted to not get into the situation in the first place. They were exhausted by the last one. Fair enough. So again, this goes back to the fact that if we're evaluating somebody for MAID under an advanced request, they have lost capacity. They do not have capacity to make a decision about having MAID today or not because they don't understand or appreciate their options. So it would be a false dichotomy to ask somebody, do you want to have MAID today, and explain it to them, because by virtue of the fact that you're there as the provider, they have lost the capacity to make that decision. And as I've noted, this patient wouldn't be eligible in Quebec because they are not in a medical state of suffering as observed by the MAID provider. So again, we recommended that the requester consider the real possibility that their disease progression may lead them to this state and how this scenario would be managed, for example, by consenting to administration of sedation pre-procedure or dishonesty by those involved. And it obviously, again, would be important to include family, friends, substitute decision makers, and anybody who is supporting these individuals. So I think my point in probably making you really uncomfortable with these scenarios is to consider that there are many people who will progress in their dementia to circumstances very similar to these. And what is that going to look like in the context of an advanced request for MAID, not only for the patient and who they were and who they are now, but also for those of us supporting these people, these individuals, whether that's supporting them as family or supporting them as healthcare providers, right? These are very ethically charged situations for everybody involved. And who needs to be or who should be the ultimate focus at the end is, as you can see, sometimes an unanswerable question. So it is, I find personally, very difficult to think about being a provider in any of these cases. And I think that will likely be reflected in the number of providers who if this becomes available to the rest of Canada who agree to be a part of MAID in advance requests. I will also share that as a MAID provider, in the context of waivers of final consent, it is very different to provide MAID to somebody who has lost consciousness and is not able to look me in the eye and say, yeah, I'm ready. And usually with a smile, yeah, I'm ready. Than the alternative when someone is comatose and I'm providing medication and I'm doing what I think they wanted, but I don't definitively know. So it is, as a human being who does this work, it causes me a lot of concern about how that will play out in practice. So in September, Quebec released some data in regards to their almost year-old at that time advance request procedure. So at that point, as of September 4th, there had been a total of 1,425 advance requests for MAID that had been added to their provincial registry. And interestingly, 179 requests were rejected. And they didn't specify in this article why they were rejected, but obviously there were some concerns about some aspect of the request. And the document that came out yesterday, the report on the national conversation for advance requests for MAID, they talked about 4 themes that came out of the data that they collected. So the first was that the principle of advance requests was generally supported, as we have seen by the data, the 58 to 76% for the 2 different categories. But there was concerns about how advance requests could be implemented safely in practice. And I think I've showed you that as well. The other concern was support for patients, families, friends, caregivers, and healthcare providers in the context of this type of care. And I think most importantly, there needs to be a greater health system capacity for end-of-life care that's needed. And not only capacity, but also education and information about progression of various life-limiting diagnoses, but also the options for people to accept or to decline care at any point and any state in their progression of their life-limiting diagnosis. Often I get questions when I give talks about dementia and MAID, and there seems to be this misperception that you either have MAID or you die this horrible, awful death of end-stage dementia. And in reality, there are, for every patient with dementia, multiple points at which care decisions need to be made in regards to things like infections, loss of swallowing ability, transfer to emergency after a fall. Every time a care decision needs to be made in the context of a capacity limiting diagnosis, the substitute decision makers can say, no, we're not going to give antibiotics for another bout of pneumonia because mom wouldn't want to prolong the life that she's living now. What we're going to do instead is provide good palliative care, good symptom management, and allow her natural death to happen. And I don't think those conversations are happening enough within our healthcare system to say that, well, the answer is everybody with dementia should have an advanced request. So last points, waiver of final consent are for patients with a reasonably foreseeable natural death, so only patients under track 1. They're not appropriate for every patient who wants MAID for a number of reasons. They're very patient and situation specific. Waivers are for patients who are already eligible for MAID, and advanced requests are or will be for those who are not yet eligible for MAID. And then understanding that the loss of capacity changes everything. So choosing MAID early, and I put that in quotes because that's variable individual to individual, while it remains a conscious choice for that person, may ultimately be the right choice for that individual. And I found an interesting quote in the article about the stats for advanced requests in Quebec. And it actually comes from Dr. Catherine Ferrier, who's actually a MAID opponent, but she talks about the fact that consenting to your own death is beyond what most people can conceive of when it's not immediate. And I completely agree with that sentiment. I've had patients, as I've talked about, who have gone through the MAID process, very much seem to want MAID as an option, talk about when I'm going to have MAID, when I'm going to have MAID. And when they actually get to that point, even with being told, you know, we should make a decision about whether we're going to move forward with this or not, are not capable of looking at a calendar and choosing a date for MAID. That is one of the bravest things that an individual might do in their life. And not everybody is capable of doing that from an emotional perspective. And maybe they shouldn't be, and there's nothing wrong with that. But I think making the assumption that now that you can consent to that, perhaps years, if not a decade down the road, may not be actually what you wanted. I've included some resources. I believe slides will be shared. And I'm happy to take any questions.
So yeah, folks were asking kind of about the, what's happening in the rest of Canada in relation to advance requests. So what do you know of potentially being the next steps with that report?
Yeah, the report came out just yesterday. It sits with government at this point to review and to determine whether this is something that anybody is interested in moving forward with. The prior documents have also, the AMAD report, the Special Joint Committee, and other collections of experts have also said that, advanced request is something that we should consider within MAID practice, but it's all going to come down to whether the government feels that this is a priority. Right now, we're still kind of waiting to see what's going to happen in March 2027 with mental diagnosis as the sole underlying medical condition. And I'm not sure that the government is going to want to tackle advanced requests in addition to that, or in place of that, or before that. So it comes down to what they're thinking about in that perspective. But I will say, just in relation to the mental diagnoses, when we gave this talk at the CAMAP conference, I had a clinician come up to me after, and they said, you know what, I was, before your talk, I was so on board with advanced requests and thought it was a straightforward thing and we should definitely do this. And I was much more concerned about mental diagnoses and how convoluted and complex that would be. And said, after your talk, the opposite. Mental diagnosis seems very straightforward, and advanced requests seems incredibly difficult to put into practice. And I don't know if we'll be able to do it. So
I find it interesting that there's been no provisions in Quebec within that year.
Well, when you think about the timeline
evolution,
with which people
I guess.
are, yeah, it would likely, these are people who the progression or the prognosis for dementia at the time of diagnosis is anywhere from 7 to 10 years, right? And so these are people who are early mild stage dementia who don't, by virtue of where they're at in their diagnosis, meet MAID eligibility criteria now. So they have a diagnosis, but they're not suffering intolerably. They're not in a state of irreversible decline in capability. So, but they think they know that this is what they want down the road. So, within the next probably 3 to 5 years, I would imagine we'll start seeing what this actually looks like in provision.
Mm-hmm. It was interesting. Somebody commented about, this idea of looking ahead to what I will deem to be as suffering, right? And that idea of it's not easy. Like if you've got a decent quality of life right now and you're trying to make this list of these are the things that would need to be happening for me to be suffering.
Yeah, I know it's head scratching. It is, from my experience watching people plan ahead and having MAID as a plan, and then getting to the end of their natural life and it not being as bad as they thought it was going to be. And I mean, that's different because they're cognitively intact and they're able to make that decision. But even then, like knowing that these things are going to happen to you and now they are happening to you and you are living through this. And even then, they're not saying, yeah, I'm ready to die. Right? Like it's a very interesting conundrum.
Another comment about that, objective versus subjective assessment was around like different cultural expressions of pain and symptoms. And so if you're trying to observe somebody who's always been very stoic and masks their pain and that kind of thing, like it would make that determination very difficult.
And we see a lot in palliative care this counter transference of suffering, right? Like the people who are watching this person go through the end of life, even though that patient isn't necessarily exhibiting signs that they are physically or psychologically suffering, the family thinks they are, right? They are struggling with this because what they're struggling with is watching what's happening to their loved one. But I just taught a LEAP course for Pallium last week in Bancroft, and the video that we show in all the Pallium of the young man losing his wife at the end, and she is calm and quiet and everything that we would want for somebody at the end of life, and yet the husband keeps talking about her suffering. She's suffering, when really it's his suffering, right? And how much of this, how do you address that in this context when now the person isn't even has told you this is suffering, but they're not appearing to suffer, and yet you know that this would be suffering for them. It's so confusing.
Yeah, somebody commented when you were sharing kind of your experience of how different it feels in providing MAID in the context of somebody who's awake and can tell you yes versus somebody who I imagine you walk in and they look comfortable.
Right. And then I didn't talk about the idea of waivers of final consent being used in patients who have dementia or who lose capacity, not because they are comatose for whatever reason, but because they have progression of a cognitive disorder. And people do choose to use waivers because there's nothing saying you can't with patients with dementia, but you run into that concern with somebody who's wide awake and conscious, but has no capacity to understand what you're doing or why you're doing it. And how do you invoke a waiver in that case when they've lost capacity, but they haven't lost consciousness? And how challenging that situation can be, which is very reminiscent of what will happen under advanced requests.
Something came up, and I think it might be worthwhile to speak to some of the safeguards around this. So, concerns around, a family member who stands to gain financially from somebody dying. What are the safeguards that are in place to make sure that, people are making truly the decision for themselves?
Yeah, I mean, that is part of why ensuring that a request for MAID currently is made voluntarily and not under undue coercion from anybody else or from circumstances. But when you add into discuss that in the context of an advanced request, I think that's why Quebec went with the trusted third party position, and that trusted third person does not need to be your substitute decision maker. They don't need to have any other role within your healthcare, and obviously should be somebody who is going to speak in your best interest. Like it would not be beneficial to name your trusted third person as somebody who might benefit from your death. I don't think there's any stipulations like there is in the current MAID law in regards to witnessing and independence of assessors that they specifically can't benefit, because I think there's also the risk of what if a person only has someone who will benefit from their death as their trusted third person, who can make this call and be their advocate, but they're also going to benefit from their death by virtue of that's the only person this patient has. So I think these are all concerns. What concerns me the most is whose lap are these going to fall into? And like thinking about how's this going to roll out in a long-term care home, right? Like with family who doesn't live anywhere nearby, who, visits every once in a while, or who, all the different family dynamics that come into these situations. And then the staff that are there every day with this person and who know them and who know what they like and they don't like and the intimate relationship that they have. And then a MAID provider who's coming in and who hypothetically may have never met this person ever, right? There is no requirement and it's not feasible to do your advanced request and ensure that the person who's going to provide MAID for you 7 years down the road is the same person.
Yeah.
So how
it's a long gap. I was thinking about the trusted third party. An elderly person might pick a friend and they might die by the time those conditions arise.
Yeah. So these are all things that Quebec is, for better or worse,
leading the way,
playing out the experiment for us. So hopefully we can learn from them. But these are all things that are going to have to be considered. And I think what I hope people take away from conversations about advanced requests is they understand that they may feel that this is the right choice for them, but I want them to think about all of the other people who are going to be impacted by this, right? And it is a lot to leave the responsibility of making this determination of now they need to be assessed for MAID, supporting, giving sedation prior to a provision, all of the nuances that I've discussed and probably many more that I haven't even thought about fall to other people because you're no longer there. And is that the best choice for everybody involved? Right? So I don't have an answer for that, but I just want people to think more about that. And I worry that in our death denying society, where we're very eager to give away the responsibility of making these decisions to other people, what that will ultimately do for the people left behind.
Yeah. And I think through your whole talk, what's come out for me is just the importance of those conversations and advanced care planning, like talking to the people who'll be making decisions on your behalf if you can't make them for yourselves. Because like you say, an infection untreated, renal failure untreated, there's,
And yet those options are almost never given. I talk about if you're at the point where you're being asked to make a decision about care, a decision means that there's at least two choices. We're going to do this or we're not going to do this. And you should have, as the person making the decision, whether you're the patient or the substitute decision maker, exactly the same amount of information about both choices. And in medicine, that very rarely happens. We have a choice here to give antibiotics or what? What does that look like if we don't, right? So just keeping that in the back of our minds, that in order to make an educated decision about anything, we need to have information for both options or more if there are more options. But unfortunately, I'm often finding, families are the ones that have to ask for that information. It's not being readily given to them.
There's been a few comments, but I think there was a question around advocacy. So, for folks who are proponents of the advanced request, and they want to try to advocate to the government to have influence the decision-making around that, what would you suggest they do?
Dying with Dignity Canada has a big campaign on right now in regards to advanced requests. So I would steer anybody who's interested in providing more support for that to connect with Dying with Dignity. They have letter writing campaigns, reaching out to your MPs and MPPs to let them know that this is something that you are concerned about and want them to have high. I think even especially now that this report has come out, obviously that will be something that's discussed in the various political realms. So probably striking now while the iron's hot would be a great idea. And I'm sure Dying with Dignity can support you in that.
One of the things I wonder, and I certainly don't want to, end on a bummer around our system, but I know there's kind of, it's already a struggle to keep up with the amount of MAID provisions because of the number of providers. And I think about, 2027 with mental health potentially, or mental illness, if you could wave a magic wand, do you have some kind of solutions that you think could make accessing MAID a little bit easier, the support for the MAID providers a little better?
I think honestly, if I had a magic wand, it would be to increase the system's capacity to have difficult conversations about end of life care options. Because I think there is a huge amount of resource that ends up being MAID focused that could have and should have been further upstream in regards to choices and options. People either wait and ask for MAID at the very end and it's rushing and it's immediate and we need to get MAID because they're literally dying. Or people hear those horror stories and so ask for MAID years before they're ever contemplating it, when they haven't had conversations and don't feel, understandably, that they have the support to know what their options are as their health continues to change. And I think MAID needs to be an option, but it should never be the only option. And we need to talk about what end of life care looks like, what palliative care is, what the palliative approach to care is, way earlier to help to ensure people are getting the right care that they need when they need it, as opposed to defaulting to things because that's all there is. Like, I'll give an example, the provision that I was part of today. This individual was diagnosed with cancer 6 months ago. Yesterday was the first day that individual saw a palliative care provider. And the first thing they said to me was, I want to die. Can you do that? They were in no state for me to have a conversation about, well, let me help you with your symptoms for a period of time to see if we can get you more comfortable. No, that conversation should have happened months ago. And yet here I am providing MAID for that person today.
Well,
wah, wah.
I think the Southeast subregion of Ontario Health East is very lucky to have you, Valerie Cooper. And we're really lucky that you came and you shared your expertise with us tonight. And just so further education. So for folks who are in Ontario Health East, we're going to be sending out the advertising soon, mid-November, we're having Hussein Sao and Sammy Winemaker do a 2-part workshop for healthcare providers around the Hope for the Best, Plan for the Rest. And as providers, how can you be supporting clients and families in harnessing those tools and that approach? And then in the Champlain region, I know we've got some offers for Canadian Serious Illness Conversation Training coming up in the new year. So keep an eye out for further education. Carl, do you have anything else we need to add for this evening? Oh, the evaluation forms.
I'll put them in the chat here now.
Thanks to all of you.
Don't forget about your wellness day. Did you mention that already?
I didn't mention wellness day. Good call. Do you think you can pop that in the chat too?
Yeah,
so
I'm gonna look for the link here.
Okay.
I always look forward to that day.
I know. We were saying we had a team meeting today. And we're like, oh, we can't wait for wellness day. So we have our online, free, full day of a wellness for healthcare providers, and that's very loose. You know, you don't have to be a regulated health professional to participate. We welcome volunteers. We welcome funeral folks. We welcome end-of-life care doulas. We hope you'll come out to our wellness day. We've got a great lineup. Blair Bingham is coming. He's got a book coming out next fall on burnout. And we have some great perspectives on happiness and lots of great things. So have a great Halloween. I'm like, you know, motivated now between all of Val's little icons and her earrings. And go Jays. We have to say that as well. So
thank goodness we weren't competing. We would have lost
I
everybody 28
know.
minutes ago.
Medical assistant dying or the Jays. Yeah.
I might have had to get off 28 minutes ago.
Yeah. Anyway, have a good night, everybody. Thanks so much.
Take care. Thank you.